Welcome everyone to the 2025 Professional Learning Series. It's hosted by United Cerebral Palsy Research Council, United Cerebral Palsy of Central Arizona, and Gillette Children's. My name is Valerie Pericini. I am the Vice President of Clinical Operations here at United Cerebral Palsy of Central Arizona. And I'm delighted today, which is an understatement, to be able to present today's speaker, Dr. Michael Kruer. He will be discussing advances in deep brain stimulation technology. I do want to make some quick reminders, though, before we start. So the session is being recorded. During that time, we won't take questions, cannot take questions during the session, but we encourage you to put those questions in the Q&A for the end of the session, and or the presentation. So at that time, we will go through those questions that you put in there. Finally, please make sure that your full name is both first and last are displayed under your Zoom display name so that you're able to receive your CMEs. It just makes the job easier for the people behind the scenes to be able to make sure we match you with your attendance. So also instructions on how to do this are posted in the chat. So if you want to look for that. And it's now my pleasure to introduce our speaker, Dr. Michael Kruer. So Michael is my co-chair here for the Research Council. We've worked now 3 years at the Research Council, but I know him because he's also an Arizonan. And so I could actually tell you that he's a pediatric movement disorders neurologist. He's a developmental pediatrician. He's a molecular geneticist. He is many things. But I actually, and he doesn't know this is coming, but I actually want to read something for you that was written about Michael a little while back. And I think it actually speaks to the character of a man, specifically Michael. And so just bear with me. It's a little thing about champions, because Michael is a champion of cerebral palsy. It says, champions aren't always someone who's won a title. Their name may never be recognized among strangers. Some champions are the quietest of victors, those that have accomplished something momentous through nothing but their own sheer determination and hard work. And so I'm going to jump because it talks about champions, our children, our families here at United Cerebral Palsy, who do truly do the work. But then this is the piece about Michael that I want you to know. Champions really are everywhere at United Cerebral Palsy. Champions like Dr. Michael Kruer, who is quietly driven by a passion for children and their families to overcome barriers. To his ears, the greatest round of applause is not in his honor, but rather the happy clapping of a child when she achieves a new motor skill. His name is recognized here in Arizona, well loved by our parents and the professionals alike. And I would say that's also national. For Dr. Kruer is truly a champion among champions. So something that was written maybe 5 years ago. So with that, I have the great pleasure of introducing my colleague and great friend, Dr. Michael Kruer, to present to you on deep brain stimulation.
Thank you for that wonderfully kind introduction, Valerie. That wasn't too embarrassing, so
No, not at all.
forgive you. So as Valerie mentioned, I'm going to be talking about deep brain stimulation, one of my favorite topics today. And so I really am looking forward to taking your questions, to hopefully engaging in discussion at the end. But there's an awful lot to run through. And so without further ado, I'd like to get started. And so, as mentioned, we're going to be talking about advances in deep brain stimulation and the impact this can have for kids, particularly with dyskinetic forms of cerebral palsy. These are my only disclosures, and I'm going to start with a video.
We always hoped that whatever treatments we're going to be able to offer are going to impact the young lives that we're entrusted with. But it's not every day that we're able to make as much of a difference for a young lady as we were for Gianna. Dystonia is actually the third most common movement disorder behind Parkinson's disease and essential tremor. It's a frequent cause of chronic pain for the kids that it affects. For Gianna, the day came where she was tired of dealing with the disability that she was experiencing every day, and she wanted something better for herself. How are you guys?
Good.
When I first met you, you were using a wheelchair to go distances. And I asked you to hold your hands out in front of you, and it was hard for you to do that. Your arm and your hand got pulled off to one side. The dystonia in your body, it was just something you were fighting against all the time. We really had high hopes for the surgery, but just how well you responded was beyond what I had even hoped for. The remarkable thing about the current technology with deep brain stimulation is that once the device is placed and the skin heals up, we now have this indwelling device, these electrodes that are placed deep within the patient's brain. And that allows us to listen in and to observe and record the patient's brainwaves painlessly while they're just sitting and chatting with us in clinic. And so we're learning remarkable things about the brain and how the signals in the brain go wrong in the case of dystonia and other movement disorders, just by listening in and analyzing the data that we're getting from our patients. What we're going to do next is we're just going to use this wand. I'm going to have you hold it over the DBS computer. This is a kind of a cartoon version of the leads of the electrodes that are present in the deep part of your brain that controls movement. But basically, what we're doing with all this technology is pretty simple. We're creating a bubble of electricity, and that bubble of electricity is just helping your brain waves to fire more normally. So just hitting a button on the iPad, like we have to do in order to read the brain waves, just for a moment, it'll pause the DBS. And so pausing the DBS just for those few seconds turns it off. And this is the part where you might feel a little something. I know it always feels a little weird, but this is talking to the device. So you can see the dystonia coming up a little bit there, because it briefly turns it off. It's pretty remarkable, but that tells us that her body, her brain still needs the DBS in order to be able to quiet those signals and be able to normalize the brainwaves.
It feels weird, like when you turn it off, because it goes back to normal. Or not, yeah.
Doesn't go back to as bad as it was, but kind of reminds you, right? Yeah. Tell you what, should we have you walk?
She doesn't use anything, any type of device to help her walk. She's outside more often now with her friends. I'm just speechless. Like, it's a wish come true.
Here at Phoenix Children's, we are leading several different efforts nationwide and worldwide to better understand how best to use DBS technology. So it's not only about doing the surgery itself, but it's about knowing what to do with this remarkable device once it gets placed. Without the support for remarkable people that can analyze that data, there's only so much we can do. And so that's where donors come in. That's where philanthropy comes in. I'm very grateful to Gianna and her family, because by allowing us to use her brainwaves, we're actually already starting to use that information to help other children.
All right, so a little bit of a shameless plug there for our team at Phoenix Children's, but this is work that's not only being done at Phoenix Children's, but also at institutions like Gillette and other top institutions throughout the United States and throughout the world. But hopefully that gives you a little bit of a taste of what deep brain stimulation can do for a child, about the impact it can have on a family. And so with that kind of setting the stage a little bit, this is an overview of the talk that I'm going to give over the next several minutes. And we're going to go through a number of different topics. We're going to start with what DBS actually is, how it works. We're going to discuss whether DBS is effective for everyone. We're going to discuss what effective actually means in the first place. We're going to talk a little bit about when to consider DBS. We're going to talk about the wonderful thing that happens when people across disciplines get to collaborate. And finally, we're going to close with advances in DBS that we're very excited about. So just to jump right in a little bit further, what is DBS? Well, as you got a taste of there in the video, it really is a form of neuromodulation. So DBS at its core is a brain computer interface. And it's something that actually seems a little bit like science fiction when we first describe it to families. DBS involves working with an expert neurosurgeon who can place leads, almost like very thin pieces of flexible spaghetti, is how I describe it to the kids, deep into very precise parts of the brain that control movement. Those leads are then anchored in the skull, and there's a tunneled extender that actually will connect those leads to the neurostimulator, the CPU device that actually gets implanted just under the skin of the collarbone. And so all of this will be done usually in one or two surgeries, and it usually takes the kids a couple of days to get out of the hospital afterward. But the skin is usually pretty well healed up in between 10 to 14 days after this is placed. And then at that point, we can actually turn the thing on. And so I'll talk a little bit more about that. But you might be wondering where this actually came from in the first place. And I could do an entire talk about the history of so-called psychosurgery or functional neurosurgery. But suffice it to say that there's a rich history of so-called lesional neurosurgery, where neurosurgeons for mostly adult indications, but also in some cases for pediatric indications, would do what are called lesional neurosurgeries or ablative approaches. They would actually heat or selectively destroy very tiny areas of the brain to induce a lesion. And in some cases, remarkably enough, that would actually be enough to correct an imbalance of brain circuit activity. And so along that process, Alim Benabid and several other of his colleagues and collaborators in the 1980s made a remarkable observation that with a patient for whom they were considering an ablative approach, they actually found themselves in the circumstance that they had to briefly place leads in the brain and stimulate that person's, older man's brain with direct current stimulation. And they found that was actually able to control the patient's symptoms by itself without having to destroy anything. And so that was really the genesis of DBS as we know it. Now you might be wondering, well, how does this actually work? So wires are placed deep into key parts of the brain. There's electrical stimulation that's then delivered. What's going on? And the truth is that we still don't exactly know how DBS works. There's quite a bit talking about how DBS could represent a reversible lesion, how it can really modulate pathologic network activity, and have a host of other effects. I think we're moving closer and closer, though, to a recognition that for a lot of these different neurological disorders and neuropsychiatric disorders, that there seems to be an imbalance in some of the key circuits in the brain. And DBS seems to control the hyperexcitability that occurs in certain parts of the brain. So as I mentioned in the video, this is a very complex, very kind of overwhelming process for a lot of families and a lot of kids at first. But if I found that over time, if you actually can break this down into terms that kids and sometimes their families can understand, that actually the concepts are surprisingly graspable. And a lot of times I'll use the analogy that we're just basically placing bubbles and we're trying to introduce just the right bubble in just the right part of the brain, a bubble of electricity that will help to control that person's movement disorder. And what you see here is actually a schematic representation. This was actually taken from one of our patients. And after the DBS is placed, we can actually do an MRI scan. We can recognize where those DBS leads are placed in the brain, and then we can create this graphic representation, this cartoon of the target nuclei. In this case, it's the globus pallidus here in green, and then we can actually show a representation of the size and the location of the bubble for that particular person. So this has really been a remarkable technology. So that leads to the question, well, okay, this seems pretty cool. Why can we do this for everyone? Well, it turns out that there are only certain conditions that are DBS responsive. And much of the early work in DBS really focused on Parkinsonism and on tremor, particularly in older adults. Over the last several decades, though, we've made a tremendous amount of progress in the field, recognizing that DBS can be quite useful for patients with dyskinetic forms of cerebral palsy. And so when we talk about dyskinetic CP, I think it's important to boil it down a little bit further and to recognize that what we're really talking about are patients with dystonia. This is where the FDA indication is really centered around, but also more recently, it's been recognized that patients with chorea, athetosis, or ballistic movements can also benefit quite a bit from DBS. Now, I think it's worth mentioning that there are other indications also outside of cerebral palsy that will come up in pediatric neurology. And so, for example, we've had patients with Tourette syndrome, patients with other movement disorders not typically seen in CP, like myoclonus, or patients with epilepsy that can benefit from DBS. We've also seen DBS increasingly used for neuropsychiatric disorders. And so it's been quite remarkable to see that things like OCD, obsessive compulsive disorder, depression, or even self-injurious behavior can actually respond to DBS. And this is a recent paper published in Nature within the last few years from Helen Mayberg's group that actually showed that if you look at patients with depression who had deep brain stimulators placed into key regions of the brain that were associated with depression, that there were actually predictors of response and there was abnormal brain activity that was seen in depression, but just in different areas of the brain as compared to what you might see for someone with CP or with a childhood movement disorder like dystonia. And so I think that this has really led to a bit of a renaissance or a great deal of interest, at the very least, in trying to really understand what this remarkable technology can do. Now, when we think about DBS, particularly for patients with cerebral palsy, it often is wondered whether this is an option for patients with spasticity. And although there have been some very intriguing articles that have been published about patients with potential spasticity seemingly responding to DBS, at this point in time, DBS, by and large, for clinical indications, is not something that's available for patients with spasticity. And so this actually becomes a very important distinguishing point, because I'm often asked, why do movement disorders specialists care so much about distinguishing spasticity versus dystonia, trying to determine if a patient's primary movement disorder really is more spastic or more dystonic? I think people rightfully will say, well, isn't it just muscle tightness anyway that we're trying to deal with? And can't we just make the muscles looser and help the patient? And to some extent, I think that's absolutely true. But I also think it's worth recognizing that there are some important differences between spasticity and dystonia. And so perhaps this is part of the reason why pediatric movement disorder specialists do get hung up on this particular topic. And I think, for example, if you look at spasticity and the treatment options that are available to patients with spasticity predominant cerebral palsy, you'll see that selective dorsal rhizotomy can be a very powerful intervention for the right patients. Conversely, though, for patients that have predominantly dystonia, we know that selective dorsal rhizotomy, or SDR, is not often a good choice. And in fact, as just mentioned, those patients may actually instead respond to something like deep brain stimulation. We also know that there are medications that will work for dystonia, but not work for spasticity. So again, even though there are many things that will treat both, there are some important differences there as well. Over the last few years, we've increasingly recognized that dystonia is more common than we realized in CP. And unfortunately, I don't have time to really talk to you guys in detail about the differences between spasticity and dystonia in this talk. That could be a talk in and of itself. But I'm happy to take any questions that might come at the end. This was a beautiful paper, though, that James Rice and Darcy Failings and colleagues published a few years ago in Developmental Medicine and Child Neurology, where they recognized they looked at hundreds of patients that had either dyskinetic cerebral palsy or spasticity predominant cerebral palsy, and they found that even in patients with spasticity predominant cerebral palsy, the majority of patients, in fact, had identifiable dystonia as well. So many patients will have a mixed picture. And I think that this figures into some of the complexity of trying to find the right patients. We also, in the movement disorders clinic, will sometimes see that we'll use DBS for patients that have more than one movement disorder. And so I think certainly some of the patients that have gone to DBS in our program in Phoenix will have 2 or even 3 movement disorders. And so I think that this is relevant, especially as we start to think about the targets. It turns out that where you put the electrodes is exquisitely important for determining how well that patient might respond to therapy. And so as newer techniques come out, and in some cases, we're considering placing even multiple electrodes in the brain of a single patient to try to treat multiple different movement disorders, this is an important point of discussion. So all of this, I think is coming from a very biomedical point of view. But I'll be the first to say that the real cornerstone of success with deep brain stimulation is really about the collaboration between the therapists and the physicians and the medical providers that are involved in the care of these patients. These patients often have very complex needs, but in a nutshell, DBS and all of the medical treatments for CP largely, as I explained to families, try to take away the bad stuff. We're trying to reduce the unwanted abnormal muscle activations. We're trying to more or less open up a door for that patient, but we have actually very little in our toolbox to help a person move better in and of themselves. And so I think that although there are some exceptions, so for example, if we can reduce a patient's movement disorder, that can sometimes allow purposeful movement to proceed more deliberately. Sometimes, for example, we can also see that the DBS has benefits for posture, but I really do think that there is a key role for therapy and for therapist providers in all of this DBS work. So what does effective mean anyway? I think that this topic comes up quite often as we start to discuss DBS, particularly among movement disorder specialists that treat kids and young adults. We'll often talk about a particular condition and we'll ask the question, well, would this patient be a good responder to DBS? I think that's an important consideration because it's also something worth mentioning that although we put our best foot forward and I showed you the amazing story of Gianna there just a moment ago, most of the patients don't have quite that dramatic of a response that we saw in the video. And so I think for a lot of the patients for whom we're considering DBS, it's a matter of really trying to find that line in the sand where it's worth it to go with what ultimately amounts to an elective neurosurgery to try to help improve that patient's quality of life. So this effectiveness can really be defined in different ways. And I think we all would agree that if a patient's movement disorder is reduced to almost zero, certainly that's effective. But is there anything short of that might be effective? Well, I think Jean-Pierre Lin's group really got us thinking more in this direction several years ago with this article published in Developmental Medicine and Child Neurology, where they talked about the fact that deep brain stimulation could actually be very effective in reducing pain in children with cerebral palsy, and particularly with dystonic cerebral palsy. And so this really kind of reflects a more recent movement in the field, a recognition that even though kids and young adults that have dyskinetic CP, that have these hyperkinetic movement disorders, they might not always be able to tell us exactly how they're feeling. But we know now that pain really is an important part of their everyday experience, and something that is unfortunately all too frequent. So when I think about why do we treat these movement disorders, not just because they're there, we treat them because, number one, they can be painful and or distressing to the kids and to their families. These movements can absolutely disrupt normal function. And I think that it's very hard sometimes for a child to try to have purposeful movements, engage in purposeful movements to meet some of those core motor milestones when they're constantly fighting against these unwanted involuntary movements. Finally, we treat movement disorders, even though it's difficult to gauge this on an individual level, but we treat them to try to prevent some of the long-term complications, including musculoskeletal complications. How could this look? Well, for example, even though a patient might not be able to get out of their wheelchair and walk after DBS, they may have better head control that could allow them to use their AAC device more effectively. They could have fewer dystonic spasms that could lead to decreases in the chronic pain that they experience. And in fact, this is often what I consider to be a very achievable goal, is pain control and comfort for DBS. If we're able to improve hand control and improve upper limb function, that can help to facilitate things like power mobility, which can be very enabling for a person. But this is really an individual determination with the family, and it's something that has led us to recognize that sometimes very different patients can actually benefit from DBS. So when we're talking about the types of patients that could benefit, we may be talking about patients whose dystonia is so severe that they're living in and out of chronic exacerbations or storms of that dystonia. These patients may often have status dystonicus that lands them in the hospital for days or even weeks at a time. That can respond to DBS. We might see patients with dyskinetic movements that lead to ballistic or flinging movements involving the proximal muscles. That will often lead to distressing situations for the kids. They'll sometimes inadvertently hit their loved ones, hit their arms or their legs on doorways or objects around them. And so reducing those ballistic movements that otherwise can lead to injury can be very, very important. Sometimes for the kids that have higher levels of function, if we can improve their dystonia and reduce the degree to which it disrupts their purposeful movement, that can actually help them to walk better. And so I think that all of these things are important considerations as we start to consider and have that discussion with the family as to whether deep brain stimulation may be right for them. So what about for those families for whom we ultimately decide that DBS is not the right option? Is there anything else? Well, of course, it depends on the circumstance. It depends on the family, the child, the goals. But oftentimes the answer is yes. And so we may be looking at other options that could include things like the intrathecal baclofen pump, things like a ventral rhizotomy, not a dorsal rhizotomy, but a rhizotomy that actually is targeting the anterior motor rootlets. Or sometimes we could be looking at something like lesional neurosurgery. And so going back to some of those old approaches, they never actually fell out of favor. And in fact, they have been refined with newer techniques, such as using high-frequency focused ultrasound in critical nuclei of the brain to actually relieve movement disorder symptoms. All right, so when should we consider DBS for these patients? When do we bring up DBS? And I think that this is a difficult question to answer. We don't have quite the same data that some of our colleagues who care for patients with chronic epilepsy have, for example. But again, there was this beautiful paper by Daniel Lumsden and Jean-Pierre Lin in London. And what they found was that, the mantra that we were all using, that we reserve DBS as an elective neurosurgery for patients that are dealing with the worst of the worst, that they have the most severe, most refractory symptoms that are resistant to treatment. Unfortunately, that often meant that by the time these kids or young adults would get DBS, they had often suffered from musculoskeletal complications. And so this paper actually started to change the way that we approach things. And I think that although there's not complete agreement in the field, we're now starting to think of DBS. For example, in Phoenix, once we've reached 2 or more medication trials, and a patient has also tried injection therapy with botulinum toxin and/or phenol. And so I think that we're starting to think of DBS for patients that might be responders earlier. And although that is an individual decision that family will have to make, we want to make sure that the families know that this is an option, that they have the chance to talk it through with our team, and that they have the ability to consider it for themselves. As I mentioned earlier, DBS is essentially an elective neurosurgery. With that said, though, outside of surgical risks, including perioperative risks of bleeding and things like infection, the biggest risk that we commonly encounter, I would say at a practical level, is the device not helping as much as perhaps the family had hoped. And so there are lots of videos of patients having dramatic responses to DBS, like the one I showed you earlier. And so I think that sometimes, even though we might tell an individual family that for your child, the benefit profile looks a little bit different, and we still think that they may be a candidate for DBS, but we think that it's important to be very upfront that we don't think the response may be as dramatic. Sometimes, even though families hear that, they don't really hear that. And I think that's a real challenge, but I think that's human nature to some extent. Valerie, you had a question? Never mind. Okay. And so as we start to talk about additional family considerations, I think that sometimes families want to know, well, okay, if there's no complications, we put aside the benefit that the device is going to give, what's the downside to doing something like this? And I think that it's important for them to know that there are certainly stimulation-related side effects. There can be lightheadedness, there can be fatigue, headaches, visual changes. But interestingly, most of the time, we can identify those side effects in the clinic. And so one potential benefit to DBS is that it is less side effect prone many times than multiple medications might be for a particular patient. And for some patients who undergo DBS, if they are on multiple medications, we are able to reduce that medication load a bit. So for some families, that can be very attractive. So again, going back to that idea of that there are a number of different types of patients that can benefit from DBS. Here's a young lady with chorea and ballistic movements as her predominant movement disorder as part of her dyskinetic CP. She had a genetic etiology for her symptoms, but she had these quite distressing movements that you can see here. And she would go through these bouts where these movements would really act up, and they would last for days or even longer, and would be quite distressing to her for just hours and hours at a time throughout the day because she was unable to control her body. This is the same little girl after DBS, and I think that you'll be able to see that although she still has some additional hyperkinetic movement, she still has some chorea, that her movements are drastically reduced, and in fact, her entire demeanor is a lot better. This is her true self, as her mom likes to say, and the DBS has really helped to bring this out a lot better, which has been wonderful to see. So you could see some of our wonderful therapists there, and this really brings us to the next part of the talk, which is the beauty of multidisciplinary collaboration. I would say that probably, actually no, for sure, my favorite clinic that I do is my multidisciplinary DBS clinic, simply because of the wonderful people that I get to work with and the depths of expertise that we get to bring to each patient. Looking at things at Phoenix Children's, we have a wonderful multidisciplinary team that includes myself and my fellows in neurology. It includes Nicole and Lauren as PT and OT. We often will have our Medtronic reps, so the device manufacturers will often allow their reps to join us in clinic. So particularly as the software and capabilities continually are updated and upgraded, we have more and more ability to program the device in different ways. And so having reps like Bill in the clinic with us can really be invaluable. In addition, we have a depth of expertise even outside the clinic, where Medtronic has a neurophysiologist named Dan that often will help participate and help us solve problems for our patients. We have additional team members that are not able to make it to every clinic as well, but nevertheless play a huge role in caring for these complex patients. And that includes Drs. Ponce and Hauptman, our neurosurgeons, Dr. Butcher, our neuropsychologist, who does pre and post DBS testing for all of our patients and helps to really make sure that families have a good grasp of the whole process and what it may mean for their child. We're supported by a wonderful MA and RN team with Belinda and Kaylee, and we would not have the success that we do at this point in time with our DBS program without our amazing coordinator, Nicole, who often is able to join us in clinic, just not every time. So I think that I'm very blessed, certainly, to have the depth of expertise that we do, and I'll show you a picture at the end. Sometimes this means that between the different specialists and the trainees, we're approaching a single child with as many as 8 or 10 team members at a single time. But we have large rooms, and we find that as long as we bring lots of toys, we give the kids time to warm up. This team-based approach actually works very, very well for helping us to not only see the patients beforehand, but also for programming visits after. So the DBS clinic at Phoenix Children's is a dedicated half day. There are also neurology-only visits in between and therapy-only visits that are available. And we've structured our clinic so that we do usually one or so pre-DBS evaluation. This is a patient who is thought to be a candidate for DBS. They get to see the whole team and be evaluated and really talk through their goals, their expectations, their questions before they ever get to, they jump into the process with both feet. Again, as I mentioned, after the device is placed, the post-DBS programming visits are really where we spend the majority of our time and effort, and it does prove to be quite challenging. I know this is a multidisciplinary group, and I know that many of you may be therapists, but I think there are absolutely key roles for therapists in the DBS clinic. I think that you can see here that our occupational therapists help us to really prioritize activities of daily living, really be cognizant of sensory needs and state regulation for our patients, especially as we know their anxieties, their state can really influence the presentation of their movement disorder. In addition to assessing all of the usual things, our therapists also help us to focus on quality of life. Physical therapy, similarly, is looking at strength, range of motion, coordination, posture, alignment, kinematics, but also looking at things like balance, trying to determine if there are any changes to adaptive equipment that are needed, and weighing in as a whole, as part of the team in terms of what this child needs as a next step. And so the way we structured our clinic is really to make it a collaboration. So that the therapists are looking at things slightly differently than the medical docs, but we're all trying to look at function, trying to look at the patients and families' goals. First of all, to evaluate candidacy for DBS, but also to track progress and make sure that we're on point after the DBS has been placed. We're also trying to use quantitative rating scales whenever we can. Things like the COPM, the goal attainment scale, the different movement disorders rating scales, and many others, as well as measures of quality of life. In addition, I think that early on we decided that even though DBS was our focus, that this really was not just supposed to be a DBS clinic, but a patient-centered clinic. And so we've set it up so that sometimes we don't end up changing anything with the DBS, but maybe we change the seating arrangements for that particular patient. Maybe we're actually helping to work up another medical concern that we think is impacting that child. Or maybe we're just really emphasizing the importance of getting that kid to physical and occupational therapy to help them build upon some of the doors that DBS is opening. So as an example of the types of patients that we might see that maybe don't have the black, or white day or night difference that we saw in the first video, but nevertheless have meaningful improvements with DBS. I wanted to share the story of another young lady. This is an 18-year-old girl who had a diagnosis of dyskinetic cerebral palsy, really thought to be generalized dystonia, GMFCS level 5. This was related to a early life perinatal injury, and she had received DBS service for most of her childhood. She was actually pretty close to getting posterior spinal fusion prior to undergoing DBS. And so this was her just before the DBS. Big cheesy smile. And so I asked her to smile. You can see her Barry Albright dystonia score down here, which is a measure of how bad the dystonia is, 32 being the highest score. You can also see that her GM-FM baseline score was captured as well. And then close your eyes really tight, like you have soap in them. Close your eyes tight, 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 tight. Close them, close them, close them. So you can see that when asked to do purposeful movements, it's actually sometimes difficult for her to activate what she wants to. And she has a lot of involuntary muscle activation at the same time. She has limited volitional movement. Stretch it out straight like that. Stretch it out, stretch it out, stretch it out. Yeah. And this is the same young lady after DBS. So this is actually a couple of years after DBS, multiple sessions of programming. What you can see is that she actually continues to have dystonia. She does not have normal function, but nevertheless, the DBS has made a tremendous impact on her overall quality of life, now allowing her to ride this adaptive bike. She didn't ultimately end up needing a posterior spinal fusion. Her GM-FM score increased, and her Barry Albright dystonia score decreased substantially. So I think that this gives you a little bit more of a sense that there's a whole range of different outcomes that we can see after deep brain stimulation for our patients. And so it's not simply a matter of saying, whether it worked or it didn't. It's really, at least for me, it's about goals and trying to match what we can offer with what the family is looking for. So now for the final part of the talk, I'm going to talk about some of the advances and new opportunities in DBS. Because as you've already seen, not every patient responds the same. And so this is something that has just made me and many of us in the field rack our brains. Why not? We're typically putting the DBS with this, we have the same wonderful neurosurgery team that are spot on with their placements. They're placing the electrodes in the same place, the same nucleus for the same movement disorder across patients, and the patients will have different outcomes. Why is that? Well, it might not surprise you, but every brain is different. Every person behind that brain is different. And it's really very true in DBS that one size does not fit all. And so we're often dealing with a situation where we have this remarkable technology, this remarkable tool where we can actually stimulate a living person's brain in a way that can help them if we can just figure out the right way to do it. The problem is that none of the kids come with an instruction book of how to do this. And if we simply take a one-size-fits-all approach, it may work for the first kid, but it probably won't work for the second, the third, or the fourth. This has been challenging also because we know that there are these differences, but historically, we have never been able to see dystonia. We can do an EEG and look at brain waves like we do for our patients with epilepsy, but in dystonia, the EEGs look stone cold normal. We can do lab testing with blood work. We typically won't find anything that helps us to be able to see the dystonia. We can do an MRI scan, and sometimes we'll find abnormalities on the MRI scan. But the first young lady whose video I showed you, her brain MRI was completely normal, despite the severity of her dystonia. We can even do spinal fluid testing, and with all of our clinically available tests, that's normal. So we haven't been able to really have a marker or been able to see dystonia except in the way that it impacts our patients. So what does that mean for us? Well, it means that with DBS programming, we've been kind of bumbling in the dark. Typically, we're programming every 2 to 8 weeks, often every month whenever possible in our multidisciplinary clinic. But as one father asked me right after DBS was placed for his daughter, I turned it up a little bit and he said, well, why don't you just crank it? And it's because we know that cranking it is usually not the best approach. The side effects are often apparent in the office. The benefits are something that will many times take time to see, but we've learned that each patient has a different brain, and each patient's sweet spot for how to stimulate that brain is a little bit different. So one of the things that's been the bane of my existence as a pediatric movement disorder specialist is this concept of overstimulation, that if the patient has dystonia and we give them a little bit of stimulation, it might help. And if we give them a little bit more, it might help a little bit more, and the dystonia gets a little bit lower. But if we increase and increase and increase the stimulation, then there's going to be a certain point where we can actually cause dystonia to happen. And this can be incredibly frustrating because, again, there's a delay in the time that from the time we stimulate with the DBS to the time that we actually see the benefit. So in some cases,
again, straight in front of you.
this is our friend Gianna again.
Just right in front of you.
I'm asking her to hold the tablet that we use to program the DBS, and I'm asking her just to hold her hand out straight like this.
Straight and steady.
She's having a hard time doing that.
How is it? What's that? It's not opening? Is it actually closing? You don't want it to? No. Try to just hold it open like me, like this. Straight out in front. Fingers open.
So again, just trying to hold that hand out like that, and she can't do it. And she was able to do it a moment ago, but I was increasing the stimulation in the office step by step, and I overshot. So sometimes we can see that right in the office, but many times we can't. Many times there's a delay. And herein lies the quandary and the challenge of DBS. We have this amazing technology, but not only do the neurosurgeons have to be spot on with placing those electrodes, but as far as the programming goes, there's more than simply just flipping it on. And so I mentioned that there are bubbles of electrical stimulation that we'll introduce for every patient. Well, it turns out that the best way to apply those may be different from patient to patient. And so I'll often liken programming DBS devices to walking through a deep, dark forest without a light, because there are, again, different patients that may require different bubbles, which means that every time we walk through that wood, no two paths are the same. As I told you, the benefits are often delayed days or weeks, which means it's really hard to see where you are in that deep, dark forest. There's a sweet spot of optimal stimulation, but it's really hard to know when you've arrived because you don't have anything to light your way. And so historically, this has meant that for some patients, DBS has been a remarkable intervention, but for many others, it's led to a frustrating cycle of guess and check. So what's new? Well, it turns out that there's an advance in DBS technology called local field potential sensing. And this is a technology that, again, utilizes the same setup as we've had historically. But this new technology not only allows us to program a patient's brain, but to read their brain waves at the same time. So before, I was just guessing and checking, and I was trying to ask the patient how they felt. Many times they didn't feel any different at all. But now we can actually not only send signals from the device to their brain, but we can record and we can listen in, so to speak, to their brain waves by painlessly recording while they're sitting and just chatting with us during a routine office visit. And so this is something that when we look back and we start to interpret this data, again, this is our young lady, Gianna. You can see that in the beginning, she had dystonia that affected both sides of her body, but it's worse on the left. And it turns out that the left side of the body is controlled by the right side of the brain. And so through in-depth data analysis that we've done in collaboration with John Thompson at the University of Colorado, we started to be able to analyze this, and many other groups around the world are doing the same. But in Gianna's case, we were able to determine that these brain waves are supposed to look like a ski slope where you start at the top and there's a relatively smooth curve through all the frequencies. But what we saw were these abnormal peaks of overexcited brain, where her brain was overly active in the motor centers that was driving these abnormal, unwanted, involuntary movements. And we saw those abnormal peaks on both sides of the brain, but we saw it particularly more prominently on the side of the brain that led to the worst symptoms on the left side of her body. So when we looked before and after, and we actually compared these waves, we could see that after several months of effective programming, we were able to take these waves, these peaks that were so prominent in our patients, and we were able to actually flatten them out and to normalize them with effective stimulation. And so what this meant was that, we've always had this sense of before versus after, and we've had this sense of if we get it right, then our patient's dystonia will decrease. But based on this remarkable improvement in the technology, we now have a sense of what's normal, not only by looking at our patients and by carefully examining them, but by looking at their brain waves and comparing the appearance of their brain waves, the power or the total magnitude of those brain waves at a point in time. And if you compare the red, which is where we started off, you can see that those brain waves were much more angry, and the power was much higher overall as compared to the way those brain waves looked at a follow-up visit where her dystonia had reduced remarkably. So essentially, we're starting to find this paradigm where hyperexcitable brain leads to this increase in the power spectral density of the brain waves, of the local field potentials. So this overactive brain activity correlates with overactive muscle activity, i.e. dystonia. And when the dystonia gets better, the brain waves are better. This has been fascinating to actually be able to follow, because we've also with these devices had the ability to not only look right in clinic, but to keep sensing and keep recording data even after the patients go home. And so this is from the same patient. And what you can see here is that she has this quite high LFP power that was in April. But then we made a change here shown by this thin vertical line, and we actually increased the stimulation intensity. And we did that, the brain wave power actually significantly reduced. But what was fascinating was that it reduced a lot in clinic, but even after going home, when we changed nothing else, the brainwave power continued to reduce. It continued to calm. So we're seeing that delayed effect that we've known about for so long, now for the first time. What was fascinating was that it seemed like the dystonia hadn't given up either. So even though the brainwave activity suppressed and normalized considerably, given enough time, the abnormal activity started to build back up until we then did another programming session and hit it again. Another thing that we've been able to see that's been quite fascinating is that when we see that the patient's dystonia is reduced, the brainwave power, the power spectral density actually decreases. So with effective stimulation, if we're programming the DBS in the right way, the brainwave power reduces. However, what happens if we overshoot, as I was mentioning to you? Well, if you look, this is a tracing from a different patient in which we actually have video that shows that for this patient, we seem to pass the sweet spot. And as we continue to program and we continue to go up different steps and push the DBS stimulation intensity even higher, the brainwave activity actually worsened. The total power actually increased. And we looked at this statistically, and we found that given the vast amounts of data that we're able to collect, that this was highly statistically significant. Some of our p-values hovered around 1 × 10 to the negative 179. So we're pretty sure about these observations. But this is telling us that not only can these local field potentials, these brain waves, help us recognize when we're programming the DBS in the right way, but it can even help us recognize during the programming session if we overshoot and we start to program the wrong way and deliver too much stimulation. So I want to be sensitive to time, but we've seen this phenomenon now in multiple patients. So this is unpublished data that we'll be submitting soon. But we're very excited about what some of this new technology, what some of our new collaborations are allowing us to do for our patients. We think that this is really going to open up even more possibilities for the future. This has led to the formation of several pediatric DBS consortia, including the PDDBS, the Pediatric DBS Think Tank, organized by Jen O'Malley out of Stanford, and led to the publication of several papers already. So with that, I know we're running short on time, but I'd be happy to take any questions you have. I'm so very grateful to our amazing team, to my laboratory, our collaborators, my family, but certainly the kids and families who spur us on all the time to do better. And I think that here you can see this is one of our amazing patients. This is her mom. Everyone else is a team member that's there to try to help this young lady benefit from DBS. Thank you very much.
Wow, thank you, Dr. Kruer, for an amazing presentation. We are so grateful. Can you hear me okay?
I sure can.
Okay, my sound, it was going in and out on my end. We're so grateful to have champions like you leading the way in this technology and these great advances for our families. So at this time, we are going to open it up for some questions, and I do have a few, but just a reminder to those on the call here to please, at the very bottom, there is a Q&A box, and that's where you can type in your questions, and I will read them off. With our first question was, did Gianna have therapy? She had great motor control.
Yes. And I think it's important to know that Gianna not only had therapy, but she also had a period of normal motor development. And so she had a type of dystonia called DYT1 that would not typically be considered part of the cerebral palsy spectrum. It's related in the sense that Gianna had dystonia, but it only developed when she was later, around age 8. And so that means that she had a period of normal motor development that probably made it a lot more feasible for her brain to adjust after we were able to suppress the dystonia, because those normal motor programs were still there. At least that's the theory. But that's thought to be one of the reasons why some kids will respond more robustly to DBS than others.
Okay, next question kind of piggybacks on that. Are there standard, or what are the pre and post assessments that are used? when assessing?
Yeah, yes. So there are a number of different pre and post assessments that we'll use quite commonly. So we might use something like the GMFM. We might use something like the COPM. We've definitely used the goal attainment scale, and we routinely incorporate quality of life measures. And so we're trying to look at function. And so a lot of times those are being measured by Nicole and Lauren, our physical and occupational therapists, and their trainees. We're trying to measure quality of life, and then we're trying to measure movement disorder severity. And so the hope is that with effective programming, we'll see the movement disorder reduce, and we'll see the performance metrics start to increase. But we'll really tailor those to the patient. And so sometimes we'll use certain dystonia scales. Sometimes we're using things like box and blocks testing. Sometimes we're using timed 3-minute walk test, for example. And so I think that we do have some leeway in how we target that for each individual patient, but it goes back to the goals that we've established from the beginning with those families.
Perfect. Thank you. Next question is, how old is your youngest patient who has shown significant improvement with DBS? And I guess significant could be loosely
Yes.
defined. Yeah.
Yes. I touched on that. Our youngest patient was 3 years old, and that's actually even lower than the FDA humanitarian device exemption goes. But that was a discussion. Even though DBS is not done on a research basis, it's done in consultation with our institutional review board, just because of the FDA HDE indication. And so there often can be an ethics aspect to this. But after careful discussion for one particular patient, we ended up placing a DBS when he was 3, and he had a significant benefit.
Wow. Amazing. All right. Next question is from Kathleen. I appreciate your insight. Do you have recommendations about medications, especially if there has been failure of 2 medications and Botox injections that you have seen be more effective, I'm guessing, than DBS therapy?
Yeah, that's a great question. I think one of the things that I'm a firm believer in is the variability from patient to patient that we see, particularly for our patients with dystonia and chorea, dyskinetic cerebral palsy. And so I feel like I have this frustrating experience where I'll use a medication and I'll start to favor it, and then because I have a couple of patients in a row that it seems to work well for, and then I'll try it for a third or a fourth or a fifth child and not get the same response. And so I think that there are some patient dependent factors that I at least certainly don't understand as well as I would like to at this point. So I wish I had a very specific, always do this, medication, step 1, step 2, step 3, but I don't. And in fact, that's something I spend a lot of time with our clinical fellows on is how to try to select the best medications for a given patient. But there's a lot of variability in practice. It's not easy.
That is true. It's an art, isn't it? Okay, that was the last question right now. We can pause a moment if anyone else does have a question. Please get that typed into the Q&A. In the meantime, Alexis, do you want to share your screen with the final slide? There we go. So at this time, unless another question pops up, Dr. Kruer, you're welcome to adjourn for the evening, and we thank you so much for your time. And if there's something that we can't answer, we will forward to you and let you know. But again, thank you for joining us tonight for a wonderful presentation and so interesting. And I think the videos are really impactful to to everyone watching and listening tonight. So thank you again.
Thanks for the opportunity, Tara, and thank you, everyone. Have a great evening.
At this time, thank you everyone for joining. Please scan or take a picture of the QR code. We do appreciate all the feedback that you give us because it really helps improve future sessions and what we look for in our presenters. So, oh, what is the oldest patient that has had DBS? I'll interrupt really quick since you're still there. So you said the youngest was 3.
Yeah,
What is the oldest?
in our practice, which is predominantly pediatric, 24. But at the same time, DBS is often performed for people in their 70s or 80s at adult hospitals. So I don't think that there's quite a bit of range in terms of what types of patients may be eligible.
Great, wonderful. Second reminder is if you did not change your name in your window, please put your first and last name. That does help our CME coordinator make sure that we are getting the certificates to those that did register for tonight. The link of the recording will be sent to those that registered, but also then posted on the ucp.org website. If you click the research tab at the main menu, you will see the recording of Dr. Kruer's presentation and any past presentations that we've had in our professional learning series as well. Our next presentation will be May 1st, and it's Dr. Gormley of Gillette Children's, and he's going to be speaking on the controversies of cerebral palsy. So you can look for the register. Yeah, I see you chuckle. I think there's a lot of
It'd be good.
Yeah, it will be good. So the registration link for that will be coming shortly. So check the website. But those that registered, I think we do send the registration links out to previous attendees as well. So with that, I think we will adjourn for the evening. But again, please, we will leave this slide up. I'm sorry, for a few more minutes so you can scan that code and complete the evaluation for us. And again, thank you for joining us on behalf of UCP, Gillette, UCP Research, and all of those involved. Thank you so much.